Hey there, good evening, everyone, and welcome to another episode of In Black and White here on YFNA News. You might notice that it's just me tonight, and that's not going to be the case for the entirety of the show. I am excited to be joined this evening on our show on In Black and White by my friend, my sister, and the co-host, part of the hosting team of our sibling show, The 13% on YFNA News, Miss Cynthia McDonald. Miss Cynthia McDonald is joining me tonight. Miss Cynthia, how are you this evening?
I'm well, Ricky. How are you doing?
Great. I am great and looking forward to such a robust conversation this evening. And I'm really glad and grateful to have you joining me as a co-host.
I'm excited about it too. I've been wanting to talk about this stuff for a minute now. And I'm really excited to have this conversation co-hosting with you.
Absolutely. You can catch the return of the 13%. Is that in January, Cynthia? Maybe you can tell all the viewers about when they can catch the 13%.
Yes, the 13% is currently on hiatus, but we will be back on January the 18th on King's Holiday. And we're actually going to be discussing the impact of King in modern day politics.
Whew, that's going to be a great one. And for those of you that are watching it, I know it looks a little different. In Black and White is hosted by two Black people. It's okay. It happens. It's what we do. So we have a great conversation tonight for you all. But before we get into it, if you are watching this over on Facebook, do me a favor, click the YouTube link in the show description so that you can join the conversation on YouTube. While you're there, like the video. Please subscribe to the channel if you haven't done so already. And be sure to hit the little alarm button so that you can get alerts for when all of our content goes live.
That's right.
Do you want to go through the Patreons too, or shall we save that to the end? Or
yeah, we can. We usually thank our patrons at the end, but we do also let people know that if you like our content, you can definitely subscribe to our channel. You can become a Patreon. Also, buy us a coffee. I like to do a little banter concerning coffee. How do you like your coffee? Every time that we have guests, and either they tell me, "Oh, I like my coffee with blah blah blah," and some point I don't drink coffee. Those people never come back. They never come back to the 13%. Because I'm like, how you be on my show? You don't like coffee? I can't deal with you.
I got my coffee ready here. And
okay, actually, well, you good.
My coffee with Bailey's today, so I'm excited about that and a little grandma.
Nice. Nice.
But those links are also in the show description, you guys. Please make sure that you click those links if you like what we do. Help us to continue to create great content for you, and get some great equipment, and continue to improve. So tonight, Cynthia, we are talking about vaccines. We have a great panel to discuss that, as well as the implicit racial biases in healthcare, or just simply racism in healthcare, because it exists. Black people deal with racism in so many different facets, and we'll be discussing both tonight. So let's get started, because we do have a lot to cover and some really great guests to bring on. We'll get started with our first guest. We have joining us from the University of Chicago doctoral program. She's a doctoral candidate in immunology with a focus on virology. Miss Elaine Kouame is joining us. Ms. Elaine,
hello.
How are you?
I'm doing good. Thank you for having me.
No, thank you for joining us. We really appreciate it. We also have from the University of Chicago, University of Chicago doctoral candidate in biochemistry and molecular biophysics. Ms. Christina Roman is joining us too as well.
Hello.
Christina, how are you? Welcome.
I'm doing all right.
Thank you so much for joining this conversation, joining us on the show. Looking forward to hearing from both of you, because you all, listen, we have a group chat, y'all, and before the show, and to see the information that was going back and forth between these two, as well as our other panel guests who will be joining us later, it's a lot, and I'm excited. I'm really excited. So let me do this. Let's start with Ms. Kouame. Can you just kind of briefly describe or go into some of the research that you've done with vaccines, where your expertise is, so the viewers have a better understanding of what it is that you do?
Oh, of course. So again, my name is Elaine Kouame. I am a doctoral candidate in immunology. So I have been working for the past 5 years on viruses. So the virus I work with is a virus that infects the gut, so the stomach. And we're trying to understand how our immune system, so our body defense system, respond to this virus. So we kind of track the immune response. So what kind of immune response you develop from this virus, and trying to see what kind of strategy we can use to block this infection from this virus, pretty much. So I also work on autoimmune diseases. So for my project, what we see is that when you're infected with this virus, you are more prominent to develop food allergies. So I really try to understand this connection between viral infection and then food allergy. So that's pretty much what I've been working on for the past 5 years. Hopefully I wasn't too fast, but yeah, pretty much viruses and immune system.
and I can hear the excitement that you have in your voice when you describe what it is that you're doing. So I'm excited to get this conversation with you. And then Ms. Christina Roman, please go ahead and share a little bit about what you got going on and what it is that you're focusing on as well.
Yeah, sure. So my lab studies the structure of RNAs. We use X-ray crystallography to determine their three-dimensional arrangement of structured RNAs. Viruses are notorious for using structured RNAs to do things that usually our cells would use proteins to do. And understanding how these RNAs manage to do those same functions without the help of amino acids informs us about how RNAs work, and also how we can intervene and maybe stop viruses that use these RNase machines to treat diseases and make various other medical advances.
Whew. So for those of you that are watching, they have assured me, both of these two have assured me that they are able to put things in layman terms. So, which is really why we're bringing this conversation to you, because there's a lot of skepticism around, specifically or more recently with the COVID-19 vaccine, right? But just vaccines in general, which is kind of why we have this conversation tonight. So, if I can, Christina, I'd like to start with you with if you can kind of help walk us through realistically what it is that takes place with vaccines and the cellular structure. How are they effective? How are they created? Right? Maybe kind of give us a little bit of some of your research on that.
So actually, I'm going to forward this question to Elaine. While I have read a lot of papers about this and I can't answer it, I know she's going to do a better job of explaining how viruses interact with the immune system.
Okay. Because that sounds good to me. Elaine, you can take that one.
Yeah. So, I mean, vaccines have been one of the greatest inventions that scientists are able to put together to protect us against viruses. We have pathogens like bacteria or, fungus. So bacteria, we have the, different drugs for them, but when it comes to vaccine, we don't really have effective drug to block them, to prevent them for causing disease. So one of the best way we can use to protect us against diseases is really using vaccine. So the way vaccines work is basically by training our immune system to recognize the virus and be ready to kill it. So viruses are very good at interacting with their host. So viruses, basically, they need some sort of door to enter the human body, right? So each virus has a unique door. So what a vaccine can do is basically recognize the structure that's required for this virus to enter the door, right? So you are training the immune system to recognize this particular structure, and by having this training, your immune system now thinks that there's a virus happening, there's a viral infection going on. So you are basically memorizing that particular process, right? So that's something that we call antibodies. So you recognize the structure and then you make antibodies. So next time when the actual virus comes, the antibodies are already there. And the way antibodies work, they basically will block that particular structure that the virus needs to get into the cell. So by blocking this, you're basically preventing the virus to infect and replicate. So you're protecting yourself. So instead of being, infected with the virus, not having the appropriate immune response, getting sick, by having the vaccine, you're basically building a memory against a potential virus.
The human body is mad crazy in how it's able to just function, right, at this molecular level, right?
Yeah.
That's crazy to me that these cells have memory to be able to do this. But when we talk about, there's a lot of skepticism around the creation of vaccines. In fact, I remember seeing a post very recently on social media that kind of compared vaccinations between the flu and COVID-19, right? And I'm sure you probably have come across this too.
Yeah.
How the flu vaccine has been studied for so long, and it's still not as effective. But we have now the COVID-19 vaccine that has been distributed, and it happened so rapidly. Can we go through maybe the technology and the science that has been used to create a COVID-19 vaccine, or just kind of what goes into the creation of a vaccine? How do we get to that point of what's effective and how it operates?
Okay, I can answer a little bit the difference between the flu and COVID-19, and maybe Tina can go over the technology of this vaccine, because that's more for expertise. So really, we have two viruses at play. I think a lot of people always compare viruses, but like really viruses are unique. So remember when I was talking about the analogy of having a particular key to open a door. So each virus has a different set of keys that really allow the virus to infect and really create damage. So the flu is different because the flu basically has something that we call host. So for example, the flu can infect various animals and can infect humans. So these type of vaccine are also called RNA. These type of viruses, are called RNA viruses. So RNA viruses are notorious because they really have something we call mutation. So basically, when they enter a particular host and they multiply themselves, they make a lot of mistakes. So you have various flavors of the particular viruses. And flu is very notorious for having mutations. So every year, when you are infected with the flu, you're basically having a new flavor of the flu virus. So it's really hard to develop a vaccine that will block that particular key, because you remember the key always changes every year, right? So it's pretty hard to target that. So because the flu changes so much, that's why we're not able really to develop a vaccine that's very efficient, because you have to think about, you have to predict what will be the next year's strain of virus, what will be the next year key. So how do you design a vaccine that will prevent next year's strain? So that's really hard. So scientists, what they do, they kind of make inferences. So they think, okay, this is what will be maybe the predominant flavor of virus that will circulate. So let's design this particular type of vaccine. So they have been very successful because of that nature of the virus. With COVID-19, it's different because this virus doesn't mutate as much, so it doesn't change as much. So it's really easy to be able to develop not really easy, but relatively less difficult to develop a vaccine, because you know that it's pretty stable, and you know that the flavor of virus that you see today will be the same you see tomorrow. Even if it change, won't be a drastic change that your immune system won't be able to recognize it. So because they're very different, it's really hard to compare them. And it's sure that this vaccine for COVID-19 was really, it took a very short amount of time, but people have to understand that scientists have been studying COVID-19 for the coronavirus in general for many years. So there was the first human epidemic happened around 2002. That was the first SARS-CoV, right? So that was the first really virus that really jumped from animals to humans. And people have been studying that for years. So I want to shout out to one of my favorite scientists, Dr. Micheal at the NIH, at the National Institute of Health. She's been working on this for more than 10 years and developing, really trying to figure out what would be the best vaccine for that. So I think when the COVID-19 started, there already a huge amount of data that scientists have collected and really understood how this virus functions. And you can imagine, having the knowledge and then having the pressure that, requires a lot of money, all those two things coming together, then you have a fast, something that was produced in a relatively short amount of time.
Yeah. I actually want to echo that, because as I was doing the background research for the vaccine technology that went into the most recent COVID-2 vaccines, I realized there's been this huge effort for the past couple of years to up our vaccine game and make new types of vaccines to address what you brought up, the fact that the flu vaccine is pretty ineffective. Researchers have been trying to make a version of the flu vaccine as they anticipate a flu pandemic coming out. So they've had this research on the back burner. And then when COVID happened, they were like, oh, we have all these technologies we didn't tell anybody about. We're about to apply them to this vaccine. And everyone in the public is like, what the heck? What is this? What is an mRNA vaccine? So yeah, there's actually lots of different types of vaccines. The one that you're probably most familiar with are vaccines made from weakened or deadened viruses. You can also make vaccines by putting features of the virus into a virus that isn't nearly as harmful, like an adenovirus. The downside of using the adenovirus approach is that our bodies have seen adenoviruses 1,000 times. And so the immune response to an adenovirus might be a little bit less strong than to a dead version of a virus. The COVID vaccines are completely new in terms of what kind of vaccine they are. They're called mRNA vaccines. And instead of having a dead version of the virus, they have a piece of genetic information that makes your cells make the proteins that Elaine calls the door or the key into your cells. And that allows your body to get used to seeing these proteins around and get used to making an immune response to them, so that when the real COVID comes along, they're like, I know this guy, and they block it immediately.
And just real quick, so we've been working on these vaccines for quite some time. It didn't just start back in, I don't know, February, right? It's actually been going on for a while. Got it. Okay.
Yeah. So these mRNA vaccines have been in development, I would say, since before 2015. I haven't done a deep literature search to see when they first showed up, but people have been trying to develop them for Zika and for the flu strains that are the most lethal. And they've even done clinical trials with the flu mRNA vaccines, which is how we knew that they worked in humans, right? We initially tested them in mice, and then we tested them in a small clinical trial with humans. So there was some background research that said these are a pretty good idea. The trick with getting the mRNA vaccines to work was to get a way to make them go into your cells, because RNA is actually really, really fragile. It breaks down super fast. If you inject RNA into your blood, these enzymes called RNases will chew them up and turn them into nothing. So to protect them from those RNases, we have to put them in a little bubble of fat that people call a lipid nanoparticle, which is just a little bubble of lipids. And that little bubble of lipids allows the RNA to be fused with the cell membranes. So the RNA goes into the cell's cytoplasm, which is where cells are used to seeing RNA. So it's not degraded as quickly. And that's also where RNA can be translated into proteins, which is the business end of how the vaccine works.
Gotcha.
Thank you for that. I was going to actually ask you about the process concerning when you were talking about the nano. What was it? The nanolipid?
The lipid nanoparticles.
Yeah, the lipid nanoparticles. Because I remember reading, I don't know if I was reading an article previously, and then someone commented on it, saying that are they using nanite technology in order for them to develop these particular vaccines? And the way that they made it sound like is that all of a sudden we're going to get injected by nanites and turn into cybernetic human beings. So shout out to Star Trek. Anywho. And I was like, I seriously doubt that we're going to turn into Borg. However, I did want to ask you, can you explain to our audience and myself, are these particular vaccines injecting RNA or DNA of COVID into people, or is DNA even a thing when we're even talking about these particular vaccines?
Yeah, that's a really good question. I take issue with using nanoparticle as the name for the lipid nanoparticles, because I agree it does sound super like nanite, like nanobody, like the kinds of things you see in horror movies about science. So I thought that was just bad branding. But yeah, lipid nanoparticles are just little bubbles of fat, like a bilayer of lipids. They have no mechanical properties in them whatsoever. In fact, a lot of research has gone into making them more and more biodegradable, because the more like the lipids in our bodies they look, the less likely they're going to elicit a dangerous immune response. But the vaccines that we're talking about don't inject COVID DNA or COVID RNA. It's actually using just a very small piece of RNA, and you can think of an RNA as the in-between step between DNAs and proteins. It just has the recipe for making the proteins. And this mRNA only encodes one protein, and it has a 5' cap, which is what our RNAs have to tell our protein-making machinery that this is the stuff you want to make a protein from. And it has a poly A tail, which is another component that tells our cells this is the stuff you want to make a protein from. And it only encodes just that one protein. It doesn't have all the other genes that COVID has. And because it's an mRNA with those two modifications on the ends, it can't integrate into our genomes. It can't replicate. You can have self-replicating RNA vaccines. Those are a thing, and sometimes those are better depending on the application. But this one isn't that kind. So yeah, there is no DNA in these vaccines. There is no genome integration, and there's no way for COVID, like the whole virus, to be made from these tiny segments of RNA.
Yeah, I think I wanted to add that it's short-lived. People have to think about it. It's just like you just ate something and that's it, right? It's pretty short-lived. it's gonna give the instruction, make the protein, so make the particular key that the virus uses to enter the cell, and then the immune system will recognize that particular key. So it's a very short, basically like sending a text, sending a text to the immune system, make this protein, and then receive. That's pretty much it.
Cool. We have a question in the chat that I thought was very interesting that I would like one of you ladies or both of you to actually answer. This is from EJ1914. I heard that the vaccine will change your DNA. Is that true? Also, could this be used against Black people in any way?
Yeah, so I wanted to know whether or not the RNA could be copied into a way, like reverse transcribed back into DNA so that it could become a mobile genetic element and hop into the genome. It can't do that. Those are things that are reasonable to think about and reasonable to worry about because that technology does exist. So you might have heard of CRISPR. CRISPR is like a DNA editing technology for living cells, and we're using it to treat like genetic diseases, and it's super cool. But I'm sure like layman people who aren't scientists don't know that like this vaccine doesn't have CRISPR in it. Like it just sounds like the same words over and over again. But yeah, this vaccine has no mechanism by which it could become DNA or like integrate into our cells or into our genomes and become a permanent part of us. That's not possible. And also because of that, I don't think it can be used against Black people in any sort of way. It's not like the government can like add in parts of our like genomes that weren't there before.
Yeah, and we also both smart enough to make that technology.
Yeah, if we could do that, we'd be doing a whole lot more.
Well, I want to think scientists are the smartest, but like really we're not that smart for sure to be so precise. But this vaccine, I wanted to say that this vaccine has been tested in like different people from different race. So I think I was looking at the Moderna data, the Moderna that was trying to be approved recently. I think they had like about 10% Black or African American. I think there were like issues whether was the vaccine tested in Black people. The answer is actually yes, it was tested. So it's also safe for people from different races.
Well, you bring up a great point there with that, Elaine, because there is a comment from Majestic DeAndre that says, I don't care about the credentials. No one can convince me that this vaccine isn't harmful. Thank you for that, Cynthia. I think that this is a sentiment around the community, the Black community as a whole, right? What is it that you can share, from, aside from, it looks like no one can convince Majestic about this, but for those that may be wondering, that about what causes or affects the vaccine, specifically the COVID-19 vaccine has or can have. There's some information going around online about people who have had negative responses, to this vaccine. What is it that you can share about what you know regarding the COVID-19 vaccine that would help solidify or at least put some people's minds at ease about what harm that it can or cannot do?
Yeah. I can talk about a little bit of the side effect that I found from the two vaccines that were released, the data they released. So most of the side effect that the people who have been reporting has to do with soreness around where the injection was done, and sometimes fatigue and headaches. And I think all these are like signs of inflammation. So you have to think about when you are training the immune system to respond to something, you also have to create inflammation. And inflammation is actually good in this case because inflammation allows immune cells to be recruited to the site of infection. Or in this case of the vaccine, the site of injection. So, you're going to have fever to allow your dilation of your blood vessel, to allow those immune cells to go there. So all these are really signs that the vaccine works. So your immune system actually moving and doing what it's supposed to do. It's not really necessarily saying that you're getting sick, just maybe saying that your immune system is responding as it should.
Awesome.
But, so I think you have to think about pros and cons of like getting the actual disease and getting the vaccine. The percentage of getting side effects that are very minimal, that seems to be very minimal, versus actually taking your chances and having COVID-19 and living with a side effect that could sometimes end up to death, right? So you have to think about those two things and decide what is best for you. The vaccine has been tested in more than 60,000 people. If you combine the two studies, they were really rigorous in terms of making sure that they respect all the guidelines, and that there's a huge data set around making vaccine, and really a lot of check and balances to make sure it is safe for the population. Because you have to think about liability. If they make something that is not good, you have to think about the repercussion. So also you have to think about investment. People invested in this, and you're also trying to save lives, right? And saving lives.
Quickly, when you say that, I was just recently on co-hosting on a show on WVON with the Buchanan and Seton show with Atiba and David Buchanan. They talked about last week on their show, the week before last, how this vaccine, the first round of the vaccine, is going to healthcare workers, critical healthcare workers, right? They wouldn't make a vaccine that's going to kill off the healthcare workers that are responsible for saving lives. I mean, that just makes sense to me. I don't know if that makes sense to anybody else, but they're not going to give this to the healthcare workers that are trying to save the rest of the world first. You know what I mean? By the time the general public gets it, we're going to be so far down the line of recipients that we'll see, what happens there. But I just, the community, the Black community specifically, we've been through so much with our healthcare system and healthcare professions. The healthcare system has let the Black community down and other communities of color as well. So the skepticism, the wanting for all this information is, it's needed. It's liable, right? We have to make sure that we get all of the facts before we can move forward in making the decision.
Yeah, actually, I do want to respond to the "no one can convince me of anything" perspective. That's actually a perspective that we as scientists rely on. Yes. We all don't listen to what people tell us. We believe what we read. So if you don't feel that any public health official can convince you of anything that this vaccine is safe, that's fine. Look at the data yourself. It's all publicly available. It's on Pfizer and Moderna's websites. I've been pulling up these papers all day, and a lot of these are open access, which means they're not behind a paywall because COVID-19 is affecting everyone. Yeah. So I highly encourage regular people to go and pull up these papers that show the data about the side effects and what percentage of the people who participate in these clinical trials have these side effects, what kind of side effects they are. I do agree that what I've been reading shows that the side effects are mostly just mild irritation, maybe a headache, maybe a fever for a couple days or one day after the vaccine injection. And you're always going to have that 1 in a million reaction where you have a super serious reaction because your immune system is particularly high strung. That's normal. That happens. And it's good to be aware of the percent chance that that's going to happen. But the best way anyone can learn this information is looking it up for themselves because it's not going through the filter of someone else's perspective.
Right. Exactly. Thank you. And I just kind of want to point out a couple of things, even in my, whole cursory research, because I am not a scientist, when it came to any of these particular developments, when it comes to vaccines. First off, in biowarfare, viruses have never been used on a large scale to cull populations. Ooh. And the reason being is because it's extremely difficult to control a virus, as Elaine and Christina have pointed out, because viruses are in a perpetual state of evolution. So there is a very real possibility that even a person or a conglomerate that's trying to actually push out viruses against a population more than likely will infect themselves. Another thing that also I've also happened to read concerning the vaccines is that one person on Twitter brought up to me that a person died. When I actually looked up, any type of deaths that came with the COVID-19 vaccines, it happened not in the United States, it happened in Brazil. And it was according to the AstraZeneca vaccine, which is still under development. It has not been approved by the FDA. The one that's actually going out is the Pfizer one, and I have found no proper resource or source whatsoever that stated that any person actually died from using this particular vaccine, including Black folks. So I'm less likely to believe that this is extremely harmful. As I've read, majority of the different issues that they were having was just mild side effects. Some people, and I think that you could either Elaine and Christina could answer this one question, and then we'll segue to bringing in our next panelist. This particular question from I want to say Yakub. If I said your name incorrectly, I do apologize. I saw a news report where one woman had a side effect of extreme fever and her temperature was reached 104.9. Are there people who should forego getting the vaccine based on this side effects? And then they followed up with people with pre-existing conditions.
Yeah, I can. Oh, you want to go? Go ahead.
No, you can go, Elaine. You got this.
I think I followed up a little bit on that story. I think it was in the UK, and a woman had like a severe allergic reaction. And I think the recommendation around that is definitely talking to your doctor, but also in terms of like, do you have any precedence of having a strong allergic reaction against a particular vaccine? So I think having those conversations with your health provider, your doctor, would definitely help you. Is your way around it. But so far, especially with the Moderna coming, or even the Pfizer, like they tested the vaccine in people with like different autoimmune condition. They also tested like even in pregnant women as well. So the vaccine was shown to be safe in various conditions. So even people with diabetes, all these conditions that make you more sick, having severe effect when you're infected with this virus. So at least in terms of autoimmune disease that we know that the vaccine is safe, but I think it's like the CDC recommended that really checking with your doctors if you have severe allergic reactions.
Mm-hmm. Yeah, thank you.
Ladies, I really appreciate all of the information that you've shared with us, and I know that we can go on and on with this robust conversation, but I definitely want to make sure that we get a chance to get to our other panel guests too, because around the conversation about vaccines and the mistrust of distrust of the healthcare community and profession, the Black community has been hit the hardest by so many different aspects of that letdown, right? So we not only have, as we all know, the Tuskegee experiment that took place in the Black community, so many different examples of how the healthcare system has let the Black community down. We continue to see that taking place in modern day, where we have a lack of resources to healthcare, substantial healthcare, right? And I think some of that even kind of goes around the conversation about the Black community not even signing up for trials or clinical trials to be able to help get information out there. But we still have a lot of work to do to be able to rebuild and regain the trust for the healthcare community, to regain the trust of the Black community. I think, Cynthia, you even had a graph of how many people are taking the vaccine or not taking the vaccine. Is that what the graph was?
I pulled a poll from Twitter that asked a question to primarily Black folk who were asked if they would actually take the COVID-19 vaccine, and this is what it revealed. And one of the things that it said that the new terminology for populations receiving the COVID vaccine is called vaccine hesitant populations, and then it went on to ask, would you actually take a COVID-19 vaccine? And as you see that 8% who asked, and this is like when I pulled the information, that 8% of the people who were polled said yes, and 92% of the people who were polled said no.
So let's discuss with two Black physicians how to regain the trust of the Black community in the healthcare profession, the things that are being done to reach out to the Black community. I'd like to first get started by bringing on our guest to add to the panel, Dr. Kerri Lockhart, who is a local to Chicago and pediatrician physician that'll be joining us too as well. Dr. Kerri Lockhart, thank you so much. How are you?
Muted.
Hold on.
I'm doing well. Thank you guys for having me. I'm glad to be here tonight.
Absolutely. And for those of you that have noticed, yes, we do share the same last name. As a point of personal privilege, that is my sister. We also have joining us, who's also a local to Chicago physician here as well, Dr. Malcolm Moses-Hampton joining us as well. Dr. Hampton, how are you this evening?
Doing well. How are you all?
We're doing great. Thank you so much to the both of you for joining us. And if we can kind of jump into the conversation, because you all are currently representing a very small population of a community within the healthcare profession, right? There are not too many Black doctors. There are not too many Black male doctors. Dr. Hampton, I think you might have like the smallest percentage there, at least out of this group. Talk to us about, first, let's start with this. What's being done to assist to create or recreate trust in the Black community with the healthcare profession?
I'll jump in. I think this past Friday, I watched a webinar from the Kaiser Family Foundation. It was a combination between them and Morehouse that this very issue about bias and racism and health inequity in medicine. One of the main things that came out of that, there's an amazing, a brilliant pediatrician and health advocate, Dr. Rhea Boyd. You should look her up. And one of the things that she highlighted was, getting to the root of, this issue, we have to first talk about it correctly. We kind of speak about Black people. She said, I wrote part of her quote down, and she said, we speak about, Black mistrust of the healthcare system as if, it kind of happens in this like vacuum or, and she said, it's really racism within our health system is what drives racial health inequities, not Black mistrust. And Black people's view of the healthcare system, it's not, and this is paraphrased a little bit, but it isn't rooted in mistrust, but it's really rooted in Black people recognizing that we live in a society where racism really shapes resources, who gets what, who gets healthcare, who gets access, and how that healthcare is distributed and provided when you actually get to a doctor, right? And it's really important that we recognize that Black people are just a little bit ahead of the game and like being able to articulate this, that this is what we see, this is what's going on. And so, kind of just minimizing it to mistrust really does our community a disservice because it's not just mistrust. This is truly based on data. And we often go back to, Tuskegee and Henrietta Lacks, which are very important, historical instances of health inequity. But, this is still happening every single day. Rick and I talked about a study that came out, I want to say it was August, about neonatal ICU Black babies having increased mortality, if they are cared for by a white doctor, and that mortality is risk of dying, decreasing if their doctor is Black. Now, I want to be very clear. I don't know a white doctor who is going in to see a patient who's Black and intentionally harming. I don't know one. Every doctor I've met, even ones who are grumpy and not very nice, really value caring for patients, I find. This is about implicit bias. And so I think when we're talking about what's being done, I would say not enough. There are places that are really doing this well. There are places that are doing nothing. And there are places that are making moves. But, my, battle cry, anyone who works with me will say, Dr. Lockhart will tell you every day, people are dying. And so there's really, for me, no excuse about why we aren't doing what needs to be done. So I don't think we're doing enough.
And yeah, you as well as Dr. Hampton both sit on diversity and inclusion boards where you are. And I think that's great. But I'm wondering, is that enough resource, or what other resources can be provided to help those who need to see where their implicit biases are? Where can we find that? Where can you find that? And do you all have the support and resources that you need to be able to create that awareness? Dr. Hampton, I'll send that to you.
Sure. So I guess when you're talking about implicit bias, the fact is that most people don't recognize that it's there. And I think this is the issue with a lot of racism. So I think, like you said, it's very easy to look at the Tuskegee Airmen and Henrietta Lacks, and it's very easy to look at, to think of Jim Crow South and to think of lynchings and like that's racism. And the reality is racism is not necessarily so overt all the time, especially in healthcare. Inside the white walls, we kind of talk about it. More often than not, it's a lack of compassion to understand that someone who doesn't look like you might be going through something different just because they look like you, and to take that at face value. And so I think more often than not, that's what actually occurs. And then the reality of how to address it is there's implicit bias training, but it has to, just like racism is something that's ultimately foundational to our society, it has to be something foundational to each organization. So it has to become one of the pillars or ideals of that organization to say that we are going to have anti-racism kind of run through our entire organization and our behaviors. So Dr. Lockhart and I have spoken on some panels before, and I've been very clear in that, in the wake of George Floyd and the kind of social unrest that followed this year, I don't necessarily trust that you're educating anyone out of their racism. I think ultimately what needs to happen is a commitment to behaviors which disallow or harshly punish racist behavior as a part of an institution. And so, Dr. Lockhart, I think, I didn't get the chance to listen to Dr. Boyd, but I think, that's spot on. We have to be able to name these things. And so, things that we've been advocating for in this year, on top of a lot of recruitment, trying to actually increase our workforce so that we represent our communities better, a strong push to actually do some research to understand how are we, Dr. Lockhart and I are still part of this medical system, and the health inequities continue. So, there are Black and brown doctors all over the place. They're not a whole lot, but they're there. And yet even we contribute in some way to this health inequity. And so I think we're not doing a very good job of identifying the behaviors that continue to push forward health inequity. And that's something that we need to focus on going forward.
To the doctors, I have a couple of questions for you. The first one, especially when we're talking about racism in the healthcare, are you all privy to data concerning adverse effects of healthcare, specifically to if we can, let me see if I can word this correctly. If we could disaggregate Blackness. And what I mean by that is that, you have people who are, Black who have immigrated, or they're first gen, immigrants that happen to be Black in the United States. And oftentimes you see when we look at, as far as like wealth and income, that they happen to do a bit better than, Black folk who descend from chattel slavery. And I am curious to know, when it comes to when we're talking about racism in healthcare, and we're talking about, not being able to get, equivalent treatment in the healthcare system, are you privy to any type of data that can actually speak upon that, when it comes to, wealth and income and just aggregating, like, the sector Black that actually gets what?
So do you mean that the outcomes would be different if you are not a descendant of slavery, and if you are? No. There's absolutely a different experience for us who descended from slavery, from enslaved Africans. Let me be clear.
No, you were right the first time, but go ahead. Go ahead.
But go ahead. No, I say it's descended from enslaved Africans, so that's how I say it. But the healthcare system are not that nuanced. They see Black people. And so when we're talking about, for example, a study, it was 2015, 2016. And I've looked at the study myself, and because I've heard different things, people are making me second guess myself if it was with medical students or residents. So Dr. Moses-Hampton, you'll have to back me up if you know about pain. And they did a study where they asked, I thought it was residents, it was a question, something like, why do Black people feel less pain? And they gave all these choices that were not scientific reasons. But there were a large segment of residents who actually chose those reasons because our skin is our skin's thicker, or the nerve endings are less sensitive. You know, that is without regard for where how your ancestors got you here. That is Black. My income does not protect me, like being a physician and having a higher income does not protect me from the outcomes of what white supremacy has done to our health system. That is demonstrated very well in the outcomes in maternal mortality. Black women die disproportionate to other races, every single one. And that is without regard for education level, without regard for income. So when we're talking about these health inequities, that piece, it's without regard, because there's, again, we know that our experience here in the United States is different, you know. It's in terms of how we got here again, like, but in medicine, you know, my discussions with my friends who are, you know, first generation Nigerian, you know, the same racism that I experienced, they don't get it differently because they're Nigerian and not, you know, their ancestors weren't enslaved. It's the same. And so that same treatment or bias that causes decision making, you know, Black people are more inclined to, more likely to get more aggressive treatments like amputations and things like that. I have not seen any data that shows that that's going to be different because you were a descendant of, you know, someone who was enslaved versus, you know, that's not different. But that is not to say that that is not an important distinction to know. I mean, it very much is. It very much is.
Dr. Hampton?
And so, I mean, I'm not aware of any of that data either. I mean, to get to your question, I would echo with Dr. Lockhart. It is my strong feeling, again, because we're built on a foundation of overt racism, but like in terms of the dissemination of care, you know, there's a few levels, right? So there's outright racism that's structural and is a social construct which would disallow from people to have access. So then the next level is access to healthcare. So one of the issues with healthcare, secondary to the fact that less people have, like you said, a mistrust or not being allowed into like quality healthcare. And so this kind of gets into a more nuanced point that like all healthcare is not created equal. Just in the different types of healthcare settings that we are exposed to, there is so much variability in terms of what we could expect in terms of just how people are, how much time is being spent with patients, how much time is spent communicating different aspects to those patients. And so the other part, and to get to the part about like where people are from, if the communication, and this is in my strong opinion, and maybe there's some literature to argue otherwise, one of the large reasons why we have these differences in outcomes from Black people, no matter what their socioeconomic background or even their like nationality, where their parents are from, is that there still is a lack of willingness to have a culturally congruent conversation. Mm-hmm. So to understand where someone's coming from and what their health concerns or questions are, and then address them in the visit. That one takes time, and two takes a willingness to be able to do it. It doesn't actually require you to be super knowledgeable. Like I might not know anything about where another person who looks like me is from and the way they think about healthcare, but I'm willing to my mind is open to like have a conversation about it, and I can make some assumptions of like where they might be coming from when they're raising concern. And so that level of communication, I think, ultimately carries really a long way, and it's very difficult to quantify.
You know, I'm so glad you brought that study up too, because I remember hearing about that and was just baffled that the people in the healthcare profession, specifically residents or even med students, I think I'm not sure, thought that Black people experience pain differently for all these host of reasons. Like, really, you know, when we talk about where trust is built, right? We know I'm just gonna put this out there. Black folks, we don't do too well necessarily as a whole with getting the research that we need and holding on to that research, right? From government agencies, from medical professionals, so on and so forth, unless it's in certain settings like church or like the barbershop or, you know, with grandmama at the dinner table. I wonder, and I can pose this to both Elaine and Christina too as well. How is the narrative or the landscape changing, excuse me, at the I guess graduate level, PhD level, in schools, in universities? What's being done to kind of help spread that awareness and education at that level so that we can get, you know, a larger scale of Black and brown people in the healthcare profession?
You know, I think it depends on where you are. You know, I think, you know, me and Malcolm are at the same place. And so, you know, it's a group effort. You know, we work from our different areas to try to bridge that. And so I'm on faculty. And so working from the standpoint of faculty to make moves and get more people there. I think across the board, you know, like I'm talking with people in different hospitals and things like that, Black physicians, about how we not only increase the numbers, how do we get information to folks in our communities and answer their questions in a way that makes sense. And coming from people, again, who are from the community, you know, anyone who's from Chicago. I'm from the west side of Chicago. I'm not, you know, from outside of the city. I'm from our community. You know, I went to medical school to come back to my community. And so, I think, you know, what we try to do is get into our communities and let people know that we are here. A lot of times, you know, we've heard this before, you can't be often what you can't see. There are many kids who will overcome what they haven't seen and say, I want to do that and do it. But you can't be what you can't see. And I wanted to be a doctor, but it didn't become real for me until I saw my mom's allergist, Dr. Cheryl Lynn Walker. I still remember her. And I remember staring at her like she was an alien because I had never seen a Black doctor before. And so that's certainly what many of us try to do, make ourselves visible and then do meaningful things about mentoring and guiding them through the process so that they can be successful. In more tangible ways, we're trying to change the criteria so it's more fair. Sure. You know, some of the things that are being used to choose doctors really don't choose great doctors. It just weeds out certain segments. So.
And Christine, I know that you also too had a comment about it as well before we wrap up.
Yeah, and in the academia space, I think things are moving in parallel as to what you brought up, Dr. Lockhart, in that it's kind of tumultuous at the moment. There's a large body of people in academic spaces that are trying to make these massive changes in the culture and the standards that we use to select people who would become a part of our institution and select people who should stay and how to review progress and how to respond to racist behavior. And so there are a lot of people who are trying to make change and reform things. And there are a lot of people who are used to academia moving at a snail's pace and are not comfortable at all with these rapid, radical changes. So for example, University of Chicago makes a lot of their racial decisions around this thing called the Calvin Report that was published in the 70s that basically says the university shouldn't get involved in matters of political issues. That's just unpopular. It's completely different now, but it's difficult for faculty to conceptualize the idea that the university population is different and sees a lot of weight and value in the university getting involved in political issues around racial identities and racial equality. So while universities are making a whole lot of changes really quickly, a lot of their student bodies and diverse faculty don't feel like it's fast enough. And a lot of the white non-minority students and faculty feel like it's too fast. So there's a huge amount of effort going into this, but it is kind of a battle.
Well, with that, I think it'd be great to came across a video that was shared actually on Dr. Lockhart's page that I wanted to share with our viewing audience, specifically for our Black brothers and sisters, as well as other communities that have been let down by the healthcare community, but specifically for our Black community. as a sense of maybe pride and an ability to regain some trust before we wrap up.
Dear Black America, we love you. We affirm that Black lives matter. And as Black health professionals, we have a higher calling to stand for racial justice and to fight for health equity. In the spirit of unconditional love for every single Black American, we have locked arms in an initiative to place the health and safety of our community at the heart of the national conversation about COVID-19. Respect for our Black bodies and our Black lives must be a core value for those who are working to find the vaccine for this virus that has already taken so many of our loved ones. Our colleagues across healthcare know that we are urging our community to take safe and effective vaccines once available. However, for this to be successful, they must do more to earn your trust now and in the future. We are on the front lines in care delivery and in key decision-making roles, from the lab to the clinic to the virtual boardroom. We urge you to hold us accountable. Please wear your masks, continue social distancing, hand washing, and avoiding indoor events until vaccines are widely available. With the holidays around the corner, we want nothing more than to break bread with our loved ones. But tradition cannot stand in the way of our health. We also ask you to join us in participating in clinical trials and taking a vaccine once it's proven safe and effective. We know that our collective role in helping to create a vaccine that works for Black people and that we trust has an impact on our very survival. Please visit blackcoalitionagainstcovid.org/love letter to learn more about the work we are doing to keep our beloved community safe. We will keep you in our hearts while we work to create a world that is healthier and more just than the one we know today. Love, America's Black doctors and nurses.
Oh, wow. Well, hey, we got to get out of here. A big thank you to our panel, Dr. Moses-Hampton, to Dr. Lockhart, to Christina Roman, to Elaine Kouame for joining us on this panel. Thank you so much. Also to our Patreons who continue to support. Want to say a big thank you to Marsha Ortega, best name ever / best mod ever, and Marlon Watson, Ian Davenport, Eric Fox, and the Cynthia McDonald. And also, Cynthia, thank you so much for co-hosting tonight.
Thank you for having me. And I just wanted to say to the people who have been watching, and I know that there still are some issues concerning this whole, subject matter that we've been discussing, and there's going to be, and we recognize that.
Sure.
And we're going to definitely, and we know that having an hour to even have this particular conversation is not enough. So we planned on doing a part 2. So please just stay tuned for that when we do schedule it, and we can really get into the nooks and crannies and even like some more questions and comments that have been coming up into the chat.
Absolutely. And to all of you all that have been watching, thank you very much. And I don't know, Cynthia, can we do the closing out? Do you know the closing out? As long as there's racism to fight,
there always will be in black and white.
Woo! Yes. Good night, everyone.
Good night, everybody. Oh, I got to get the video together. My bad, y'all.